Let's talk about the pathophysiology of heart failure. Heart failure is a syndrome and it has multiple causes. The end result is that there is inadequate pump function of the heart, which means that the needs of the body are not met and there is increased fluid that backs up into the peripheral tissues and the lungs. This is why historically it's been known as congestive heart failure or CHF. As I said, heart failure is a syndrome. It's not any one thing. A syndrome is a group of symptoms and signs that occur together and give a characteristic clinical picture. And heart failure is the common end result of many diseases, including valvular disease, pressure overload, loss of muscle, loss of contractility, or restricted filling. Table 1 in Chapter 10 of Lang goes over some of the causes of left ventricular heart failure. You don't necessarily need to memorize this. I just want you to understand that there are broad categories that lead to heart failure, including volume overload, pressure overload, loss of muscle, loss of contractility, or restricted filling. Note that some of these will affect the entire myocardium, notably poisons, infections, and genetic mutations. So these are not solely causes of left ventricular failure, and some of them certainly will affect the right ventricle as well. And the patient will present with signs and symptoms of biventricular failure. Also, left ventricular failure is the most common cause of right heart failure. So many times a patient will have one of these underlying diseases or causes and again present with symptoms of both left ventricular failure and right ventricular failure. The pathophysiology of heart failure is complex and needs to be understood at multiple levels. There are the changes in pump function, including decreased output and decreased filling. There are neurohormonal changes, most notably upregulation of the sympathetic nervous system, as well as upregulation of the renin-angiotensin-aldosterone system. And then there are cellular changes as well. It's always important to go back to our normal physiology and keep in mind the pressure-volume relationship of the ventricles. Of course, we have diastole over here and systole represented here, with isovolumetric relaxation and isovolumetric contraction. And of course, we know that cardiac output is heart rate times stroke volume, which gives us milliliters per minute. And normal cardiac output is around 5 liters per minute, but of course, this varies widely depending on the patient's body size and whether or not they're active or exercising. Cardiac output is difficult to measure directly, so clinically we use the left ventricular ejection fraction, which is stroke volume over the end diastolic volume, so the amount of blood in the ventricle right before systole. And this fraction is called the ejection fraction, and normal ejection fraction is around 55 to 65%. Now, I want you to know that end diastolic volume is the term we typically use clinically, but this is essentially a preload synonym for preload. So preload and end diastolic volume are the same thing. So looking at the pressure volume curve in systolic dysfunction, we remember that normal contractility is represented here by the red line. And in systolic dysfunction, there is a shift of the contractility down and to the right. So we have a new contractility represented here by the dashed line. So we see that in systolic dysfunction, we're operating with this contractility, and therefore we have a lower stroke volume. So we still have our same filling over here, and then beginning of contraction, and then ejection of blood that's in the left ventricle. And you can see the lower stroke volume compared to the normal stroke volume in the red curve. We easily see systolic dysfunction reflected in an abnormal ejection fraction. So if a normal preload is around 110 mLs and we have normal contractility, the left ventricle ejects about 70 mLs. It gives us a normal ejection fraction of 64%. In systolic dysfunction, we have the same preload, but because of the loss of contractility, we have a lower stroke volume and our ejection fraction falls. So we say there is systolic dysfunction anytime there is an ejection fraction of less than 50%. In diastolic dysfunction, we have normal contractility if there's isolated diastolic dysfunction, normal contractility, but the diastolic pressure volume curve, normally here, is shifted up and to the left. So there are elevated pressures during filling. Normally, right before contraction, we're at this pressure, represented by A, but with diastolic dysfunction, there are elevated pressures, and so we're starting from a higher pressure point just prior to systole. Because the left ventricle is at a higher pressure with diastolic dysfunction, it's not going to fill as well, and so we see this reflected in less filling and a lower stroke volume. Now, this isn't always captured as obviously in the ejection fraction as it is with systolic dysfunction. So remember, in a normal heart, we'll have 110 mLs as our preload. Contractility is normal. We eject 70 mLs, giving us an ejection fraction of 64%. Now theoretically, in diastolic dysfunction, you could have good contractility, but your filling pressures are elevated. Therefore, you're starting at a lower preload or a lower end diastolic volume. So normal contractility, but a lower end diastolic volume right before systole, which gives us an ejection fraction that appears normal, and it is normal. But you can see that your cardiac output will be lower because we have a lower stroke volume. And additionally, the elevated pressures, which we see back here in the left ventricle, create problems, and that's what we're going to be talking about next. So, systolic versus diastolic dysfunction, which one does a patient have? In reality, most patients with heart failure actually have a combination of both. A lot of times we're going to be giving you scenarios where we really try to talk about one versus the other, but just keep in mind in reality that many patients with heart failure have some component of both. In the next video, we'll talk about the consequences of elevated volumes versus elevated pressures in the left ventricle in systolic versus diastolic dysfunction.